Great. I think we'll go ahead and get started. We still have some folks coming in, but we'll proceed with our discussion here today. So thank you very much for joining us for this panel discussion. This is the last workshop in our series that's titled How We Talk with Research Participants, the Art of Communication. If you missed any of the prior sessions or want to revisit them, all of those recordings are on the ICTR YouTube site and also on the registration page that you use to sign up for today's session. And we will pop that link in the Zoom chat as well. So highly encourage going back. The prior 4 sessions were wonderful. So well worth revisiting. A couple notes before we begin the panel discussion. I did want to call out Ali and myself. We run the Recruitment and Retention Resource Center here at the Institute for Clinical and Translational Research. We are like this dog in the meme. We are here to help. If you have any recruitment or retention challenges or questions, or if you'd like help planning recruitment for a study or troubleshooting, please do reach out. I have a couple more services listed there, and we are just an email away and would love to connect with you. And I'll pop the email and our consult request form link in the chat. We do also have a new resource. This is new just in the last 4 to 6 weeks. It's a recruitment materials repository. So this is a box.com folder that is packed full of cool stuff, like the meme here. It's a bunch of things. There's over 150 materials saved in there, everything from recruitment flyers to ads promoting, videos promoting studies or videos explaining studies, social media ads, study newsletters, lab newsletters, lots of good stuff. And this is really designed to be sort of inspo material idea, creating material for anyone who creates participant-facing material. So if you were ever tasked with making flyers or anything participant-facing and you work at UW, highly recommend that you request access to this. We will put the access request link in the Zoom chat, and it's just a very short form that you fill out, just your name and your department, your email address, and then we can add you to the box folder. We want to keep maintaining this and adding to this. I do want to put a plug out. If you have anything like a recruitment letter or a recruitment script that you are willing to share with the research community here, please let me know. We currently do not have any examples of recruitment letters or scripts, and we would really like to add those. And yeah, thank you, Ali, for putting that in the chat. So let us know if you'd like access, and hope that this is useful to folks. Ali, I'll turn it over to you.
Okay, I have a couple housekeeping items and reminders similar to our past sessions, but this time we'll actually be pausing for audience questions periodically, but feel free to also pop your questions in the chat at any time. We'd also love to hear your thoughts and ideas on the items that our panelists are going to be discussing, so also feel free to include your advice or your suggestions or stories in the chat as well. The more the merrier. And then also just a reminder, please ensure that your questions or comments don't include any confidential information or any PHI. And then if you ever have questions about what you can and cannot do around recruitment and communicating with study populations or participants, please reach out to your IRB reviewer. They can be super helpful there. And then also, as Anne mentioned, these are all 5 of our sessions have been recorded, and we will have those up on our registration page. And we'll also send out an email with the information with the recording and slides and whatnot after the session. I think I got everything there. Okay, and then we thought before we introduce our panelist, we would quickly take a poll. So this is a Slido poll that you can either perfect. And just put the URL in the chat. You can also take a picture of the QR code or scan the QR code. But what's most challenging about communicating with study participants? So we're hoping to kind of hear your challenges that you're facing. If you can just take a couple minutes to put those in there, can help inform our panelists on what you might be struggling with. Maybe shape some of their answers. And then if not, Anne and I can also respond if you're looking for additional assistance. Looks like a lot of phone tech, kind
Hmm.
of hard to get a hold of people. The retention with the engagement throughout the 18 months. Timing.
Hmm. Yeah, balancing sort of selling the study, but respecting people's autonomy
Oh,
and
troubleshooting
FARA.
Advera. Yeah. Oh, in the chat. Yeah. Verotech help.
Couple things around consent and long consent forms and dense consent language.
PET scans and the radiation. Yep. That's a challenge. Consents. Yeah.
Hmm. Great. Well, thank you, everyone. That's useful. And Allie and I kind of mine texts like this for thinking about future programming and future events too. So anything that we don't speak to today, we'll certainly try to cover it in future events. And then Allie, do you want to intro the intros here?
Yeah. So, we are so lucky to have our panelists here today. So we have six panelists. Um, Everyone is from, different backgrounds, different study populations, different departments. So we really have a great, rich knowledge base here today to answer some questions. So each one of our panelists is going to introduce themselves. And then also we have a question, which Anne, I can drop it in the chat just so people online can see. We're going to ask every panelist with their introduction, what's a key takeaway you've learned from speaking with prospective and current study participants? So, Audrey, I guess you are up first. I will let you start your introduction.
Great. Hi, everyone. I'm Audrey. I am a research nurse in the emergency department at UW Health, both at UH and EMH. I do have a background as an emergency department nurse, as well as a clinical research nurse inpatient on the clinical research unit years ago. So I primarily work with patients who are in the emergency department, though we do have some follow-up calls. And follow-up visits when they are not patients. Outside of work, I'm starting to become a family practice nurse practitioner, but I anticipate that I'll continue working in research. Um, what a key takeaway that I've learned from working with patients that clinical research patients is that, especially in the emergency department, is that even during times of acute illness, I found that patients are generally still interested in helping, and are glad to be given the opportunity to participate and help. I think we have a pretty altruistic bunch here in Madison.
Hi, everyone. My name is Jaime Goldberg. I am a clinical assistant professor at the School of Social Work. My area of focus is aging and health, and my clinical background is as a palliative care social worker in the hospital setting. And I would say my key takeaway is approaching every encounter that we might have, whether it's a potential participant, a long-term participant, with curiosity and humility, remembering that this is a person first and a participant second.
Hi, I'm Jennie Matthews, and I am a research coordinator in the emergency room at the UW Hospital and also at the East Madison Hospital. I primarily recruit, enroll participants as well as complete all the assessments for the different studies that we enroll. My background is as an EMT, and I used to be a tech in the emergency department as well. But I've transitioned now to full-time research, which is wonderful. Um, Outside of work, I really like to motorcycle, and I also enjoy cooking. So there you have it.
And Jennie, did you have a key takeaway you wanted to open with? I know we're going to unpack all of this in future questions, but
I sure did. My key takeaway really is that I have found that people really latch on to a purpose. So, like if telling them what the ultimate goal is, or how the device or how the study is going to help people in the future, they really latch onto that, and it really means something to them, and it makes them motivated to participate.
great, thank you.
I should have kept my slide a little shorter here. But good afternoon, everyone. My name is Lise. I am a qualitative and user-centered design researcher at the Center for Health Disparities Research under Dr. Fred Ketchum, as well as a core member of the Wisconsin Latinx History Collective. So in this way, I research ways to improve shared decision-making processes and ethics. So this is within the work under Cheddar. And then, of course, analyzing the education and social experiences of migrant communities in the diaspora, which is through the Wisconsin Latinx History Collective. So primarily within my fields of work, at Cheddar, I work specifically with PCPs, primary care providers, as well as with older patients. And then within the context of the WLHC, I work with migrant origin, Latina, and Indigenous Latina youth and families. Outside of work, I enjoy spending time with my wife, my family, with my almost 2-year-old now as well. And then, of course, biking. Actually, I didn't add that. Well, actually, no, that's in there. But of course, the weather's not really that well for that right now. But I love traveling as well, especially going back and forth to Ecuador to visit family. One of the key takeaways for me personally with working with patients across, the fields of education and health has been, clear, transparent communication, which it might, be just a given in a sense, but I believe that when communicating with participants for any, type of research study that one's conducting, being able to, answer all the questions that they're asking of us is crucial for individuals to, if they want to participate in our study, but also, understand to perhaps the rationale of the risks and benefits of participating within one study. So I think that has been sort of my key takeaway, one that I bring across different fields.
Hello, my name is Monica Bruce. I am a research coordinator in the Okonkwo Lab. I coordinate the Super Aging Research Initiative, and Super stands for Study to Uncover Pathways to Exceptional Resilience and Agency. So it's not just like you're a superhero, which a lot of people are like, how do I know if I'm a super ager? So I really enjoy the work. I get to work with adults who are 80 and better, but they're performing like they are 20 years younger than their stated age. So I can really relate to the comments earlier about difficulty catching up with people, because my super agers are always busy. They're always doing something. So trying to get in there and get visits scheduled, it can really be tricky. I come from a background of speech language pathology, so I have experience working with older adults and children just across the lifespan. So as far as challenges and things that I have learned, this was a tough one for me to answer, but I think I've come away with two. The first one is, you've all heard about the golden rule, right? Treat others how you want to be treated. But when you're working with people, especially people who you're asking a lot of, and with studies, let's just face it, we're asking a lot. Um, so I try to treat people better than I want to be treated, not just how I want to be treated, but better. And then the other piece is making sure that we are listening. I once heard that we have 2 ears and 1 mouth so that we can do double the listening than the talking. So I always try to keep my ears open. That just helps to be able to meet them where they are, get a better understanding of who they are and what their needs are. And sometimes the needs may not necessarily be, I'm going to be a super ager in your study. Sometimes the needs are, I'm a caregiver for my spouse or partner with dementia. How can you possibly help me? So then I come up with some different resources that I've heard about because I was listening from other studies or other areas that I can connect them with. So the listening and treating people better than you want to be treated is something that I've learned.
Hi, everyone. I'm Veronika. I'm a research program coordinator at the Weissman Center, specifically working with research with early brain injury and the ability of the injured brain to recover and continue developing. And this means working with families who have had a child with an early brain injury and also families who have a typically developing child, and working with populations of the kids being under the age of 2. Which really means working with families. I can say I recruit infants, but it's really the families that I'm speaking to. And my main key takeaway, I'll piggyback off of the listening, and that listening is a developed skill and it takes practice. And it's an active learned skill, and that's something that it has been very relevant in our lab recently. And then to add another something new is knowing what you know and being confident in what you know and the information you share with the research participants, and knowing who you can ask questions from within your team and your coworkers to get answers or to get questions answered. I think that's really important to not be overstating something or having to backtrack because you shared something that maybe wasn't necessarily true. But really understanding who you can go to and being confident about, one, telling participants that you're going to ask someone and get back to them, and then actually getting back to them and knowing who you can go to get some questions answered.
Great. Thank you so much, everyone. I'm going to stop screen sharing so I can get kind of my Brady Bunch view of the panelists here with all their cameras turned on. And we're going to switch now into Allie and I are going to alternate asking questions, and anyone on the panel can respond. And I do want to just reiterate that we would love other folks. If you have responses to the questions, we welcome those in the Zoom chat. We also very much welcome asking questions, and we'll pause periodically for attendee questions, or you can put those in the Zoom chat at any time. But my opening question to anyone on the panel who would like to speak to it is sort of a simple one, but it's a big one. What do you do to build trust and build rapport?
I'll start this one off. So I'm often speaking with families right after they've had their child and soon after their diagnosis of having had an early brain injury. And I always like to start my calls with asking about the family and getting to know them rather than just spewing information at them about our study. So getting their story, getting some history, and that also helps build that listening component for them to know that I'm listening. I also like to prepare by having a basic understanding of the possible diagnoses that we work with, different medical devices that are typical with the diagnoses that we work with, different medication, and it helps give families a peace of mind that we know what we're talking about, and that it's a space where they can share their experience and be listened to, and also get the information that they need to know about participating.
I can go next, and maybe Jennie can jump in with me. But in the emergency department, we don't really have too much lead time. We have a patient who comes in who has a diagnosis or a test ordered that fits the need of one of our studies. And I find that when we enter a room, patients in the emergency department have a sense of urgency and are eager to have answers and to discharge or, get to a different destination. And so when we enter, I find it, they kind of hope that we're somebody else. And and we're people who don't have answers, and actually we have an ask of them. And so just introducing ourselves well, saying, we are not necessarily part of the care team, but we have a research opportunity for you. Would you like to hear more about it? And then taking the forking paths from there. But I don't know, Jennie, if you have anything else to comment on that. Like, it is kind of disappointing to have someone enter your room who is wearing scrubs and doesn't have anything for you other than a research
Yeah.
opportunity.
Yes, it is. It is a little bit hard to be like, no, I don't have any answers for you, but I do have a study for you. Um, I think that for me, a lot of like what I like to do is, of course, the introduction part is good, but also like acknowledging that they are not having their best day, and like, that it's even sometimes people will tell me a little bit about what's going on for them today, and just making a little bit of space for that is good. And then I think it also works better to ask their permission for every step going further. Like, can I tell you about this study? And um, would you like to hear more? And does this sound like something you might be interested? Would you like to hear about that? Like that kind of stuff. I think it really goes a long way, especially when they're in a position where they feel like they don't have any control over anything.
I can go ahead next here, and perhaps mine might be from derived from various experiences I've had. But so my current role, I know at Cheddar, I don't specifically do the actual like, recruitment process per se. We have another research specialist who helps us with that part of essentially, well, first of all, looking to see the appropriate participants that could be part of our study, and then what I actually do within that process is actually do follow up with that specific individual that we sort of understood that could be a potential candidate for our study, and then or I myself will look to see either by conducting the consent process, which for PCPs or when getting in touch with PCPs, it's a little bit more of trying to assure that we don't do it for a long period of time, in the sense like basically being understanding of their time. They don't have a lot of time, so we have to be pretty quick with that. But by that moment, they've already received their consent form. At that time, talking with me, that's the moment that they can ask any questions. So I open it and state if there's any questions that need to be asked at this moment. I'm here to address those. And then of course, especially with patients, we also do have an additional component of, especially working with Zoom, if their Zoom if they understand how to use the Zoom portal, if we need to provide them any tools or facilitate anything for their experience using Zoom to be better, that is the moment that allows me to not only assist them with that part of the, of eventual study conduction, but also of creating repertoire. So with PCPs, it's of course, presenting myself, acknowledging that I'm part of the research study, and then of course, any questions that they may have related to the lab or my role, I answer them at that point. And with patients, of course, it tends to be a little bit of a longer conversation. So really any questions related to the study, I would be addressing them at that time. And then even questions as to like, how was I recruited? We would also address that question as well that way too. From my experiences working, for example, with migrant origin families, that actually it spans a little bit longer because with creating repertoire with communities, especially that are minoritized or both ethnic, racial, language, or even citizenship status, it does take a little bit longer to create that type of repertoire. It's not a single call and hey, you want to be part of the study? Good. No, it takes a longer period of time, and especially if you're looking to do work within international settings. So I've done research in Ecuador, for instance, within indigenous communities, and that's not a simple one trip, go and do it. For me, it's been sort of a consistent process of being in touch with local community members, with leaders, making connections to other communities that I personally am not part of. There's a big, preparation time for that. So something to consider, especially if you're looking to do international-based work within this field, is to definitely consider time for creating repertoire, creating relationships, because that is the main thing there. But within clinical settings, it does move pretty quick. So definitely, having enough time to be able to address questions is very beneficial for you to be able to create that relationship.
And now I'll just add on to what Luis was saying with working with certain populations. It's going to be important for us to keep showing up. I mean, you may go to a tabling event. I do tabling events. You may go and no one signs up for your study, or maybe you get a couple and they're probably not eligible, but that's okay. Keep showing up. Eventually, some of the people run in the same circles or know people in the same circles. Keep showing up to the outreach opportunities. There are people, like even recently, someone I approached and initially it was a no. Somebody said, I think she'd be a really good candidate for your study. And she said, no. I showed up again at a wrap info session and same person came through and she was like, I think I'll sign up. I'll do the phone screening. So it's really important to just keep whatever it looks like and just be honest, be, truthful. It's a lot of work and be honest that yeah, this is really time consuming, but we appreciate it and this is the data we're going to be collecting. Just be really transparent, make sure you're not hiding anything. Show all of your cards, even and it can be kind of a personal thing, being vulnerable and it being okay for you to be vulnerable in front of potential volunteers and participants. And just, when you don't know something, say, oh, I don't know. Or when something's hard, say, yes, this is hard. This is challenging. This is time consuming. Oh, I understand you're claustrophobic. Maybe an MRI isn't for you, but I'm willing to make you as comfortable as possible. You want me to hold your hand through the blood draw? Okay, yeah, you just put it all out there and be very honest and transparent to build that trust and keep showing up.
Just to build on what everyone else is saying, I would just also add the importance of intention, which I think is a lot of what Monica and others were getting at. Participants can tell when you're doing this pro forma. They can tell when you have boxes to check and things to get done. And they can tell when you're there because you want to be and because you want to form a relationship with them to be able to move forward. They can tell. And so I think showing up with intention to build that relationship and to build that trust is really important. And then just really thinking about the nonverbals and like how we show up. So things like leaning in and eye contact and things that might seem so simple, but I've definitely seen gone awry in recruiting efforts. And coming back saying like, Jamie, why won't they talk to me? It's like, well, you came in with your clipboard and your checklist. Of course they're not going to talk to you.
Great. Thank you so much. Yeah, communication is quite the art. So, okay, so the next question that we have for you all is, what do you think discourages people from talking with you to learn more about research? What do you do to, what do you avoid doing?
Okay, I will try to answer this one. Something that I have to remember, I can get really for lack of a better word, nerdy or geek out and over enthusiastic about it. So I have to remember, hey, Monica, chill, everyone isn't there. And don't use all the, big words, come with plain language and just bring it down a notch because they just might not be ready on that level. They may not want to hear all of the scientific terms and all of the technical things and may not understand all of the language and the consent. So just be ready and prepared to bring it down a notch sometimes.
I'll add to that of specifically with the vocabulary. I find it with working with people who come from different medical experiences, their physicians having shared information in different ways and having used different words and vocabulary. I do my best to keep my language to match what the families that I work with use. So whether they're using brain injury or stroke or bleed or hemorrhage or whatever it may be, because it can be, I've definitely sensed that of me using words that they're not used to, or that's not the ones that they've heard, and kind of starting to maybe not listen or not be as engaged in a conversation. And with that, also potential prior negative experiences, specifically with talking about their diagnosis or all that it may involve of the care that they've received related to it. And so that, of course, goes back to what we've touched on of listening and understanding the perspective that the potential research participant is coming from. And I don't know, the question was phrased, how do we avoid doing it? I think there's lessons learned from experiences that we can implement in the future. And also it's a continuous awareness of it. And I think that there's definitely things that work for one family and just don't work for others. And it's a balance of finding what works for who when you're communicating with them. So I mean, of course I avoid some things, but are also things that are kind of fitting the situation and making it work for specifically the potential research participant that you're working with.
Yeah, so like just basically mirroring what was mentioned here already, but definitely plain language, clear language is crucial for, being able to not have these instances or minimizing these instances. Definitely trying to avoid potential problematic language that could cause some discouragement. But also, like as mentioned before by Veronika, acknowledging also that potential discomfort and then addressing, ways that, your research study is looking to perhaps address a question that this potential problem, is derived from. Could also be a way of saying, you're contributing to, science or research that is looking to address some of these issues or problems that you're currently facing right now for other families, for other and maybe that might be a direct benefit for your specific research participant, but that could be sort of a way that you can navigate that question or those types of questions. Another way or another perhaps technique for me also when it comes to trying to do recruitment, and this is something I learned with doing survey research at UW Survey Center, or even working within all of us. Shout out to Joel, I think he's one of the attendees here. Is definitely also assuring that they have time to talk about the topic. And when you make calls for recruitment, you're very excited, basically jumping in and saying, "Hey, we're doing this research study. Would you like to participate?" Sort of thing. But with folks, sometimes they might give you a call, and maybe they might be a student going to class and like, I don't have time right now, and they'll just click call end the button, end the call there. And or other folks that just don't have time and might think that you're just an infomercial or something. And so, trying to definitely, obviously note where you're calling from, the university, noting the purpose of what you're looking to do is also crucial, but also saying, hey, I understand, is there another time that or day that may work best for you? Making some time for a longer conversation is also a good point to, start out if maybe it's an inappropriate moment to have this conversation. And that way you're also showing respect for your potential participant, that you're making time for them, and that in the sense too, it is their decision to continue on if they're available to do or want to do this particular study. So it gives them advantages as well. So that's the way, sort of respectfully, how I manage or try to manage these types of circumstances.
I think in the emergency department, one of the things that discourages people from talking with us is like just their personal situation or how they are feeling about what's going on for them. And, sometimes people are just like too overwhelmed to consider another thing, or feel like they've already had enough blood drawn or had enough people to talk to. And so I essentially, for that kind of stuff, I sort of avoid assuming that anybody has the resources to talk to me when I walk into the room. And, I don't like approach it as though it's going to be a fail, but I do give them, I feel like I'm saying the same thing that I said before, but giving them a lot of personal choice about each step that we go along, and making sure that I'm not just assuming that they have the capacity for what I'm doing.
I'll just jump in and mention for my dissertation work, I did a qualitative study where I interviewed adult children who were harmed by a parent in childhood who are now caregiving for their parent through a serious illness or their end of life. And so it's an intense topic, as you can imagine. And so I just wanted to mention with that as my lens that we don't know what people bring to the encounters that we have with them all the time. Like clearly I was recruiting people who I knew had some kind of trauma history. And so I was told when I was, going into my recruiting phase, like, Jaime, nobody's going to want to talk to you. And obviously it was self-selecting, but the people who did participate were really eager to share their stories. So I think on one hand, not assuming that somebody who might bring something to the table that might be difficult, not assuming that they don't want to participate, but then also being really, really careful and very sensitive, and creating a safe enough space for them to be able to participate and share, and talk through their worries and their concerns. So there were, for me, during the study that I did for my dissertation, there were a lot of pre-talking before the talking, which I think is some of what Luis was getting at. And so I think that also gets at, like, you can't rush this. This is really, part of the rapport building, part of the connection, I think helps to, with some of that, people who may be discouraged because they're scared of what this might open up for them.
I have a final kind of low-hanging fruit, which is calling from a recognized phone number. And I think that the technology is advancing at a, rapid clip. And there are a lot of ways to, change how your phone number appears when you're calling. In our department, we use the paging system, and so the call going to somebody is they recognize it as the UW Health phone number, which I think is very helpful. Historically, we weren't doing that and had fewer people interested in answering or calling back. So it seems like kind of an instant rapport building with a recognized phone number. So,
Audrey, that's such a good point. And if anybody, I hadn't heard about the paging system being one route to that sort of phone legitimacy. If folks have other tips about how to control how your phone number appears to the recipient, we would love it if you could pop those in the chat. That's been something that several teams have asked us about, and IT has not been able to assist us with. We've been told it's sort of based on the recipient's cell phone carrier. There's just a lot of variables, but if anyone has found other ways that work, we would love to hear that. I also wanted to pause to see if we had any questions from attendees. Just checking the Zoom chat, but if anyone has a question, feel free to unmute, and I will awkwardly pause here for about 10 seconds to see if anyone has a question. So my next question for the group, we know obviously that communicating and building trust is very challenging. Each of you has spoken to challenges you face, and you're in difficult contexts for a lot of this research. I'm wondering if any of you has a story of a time about, when things went wrong, when you were speaking to a prospective participant, and what happened and what you took away from that, what you learned.
I'll start us off on this one. So I, with the research participant pool that we work with, we do have methods of approaching families in their care setting. So whether that be in the NICU or in a clinic or soon after a clinic visit. And this is so families are receiving their care, and I or someone who knows about the study goes to approach them and tells them about the study, sees if they're interested, and we get contact information to get in touch after. And I've had very varying experiences with this, kind of going back to what I spoke about earlier, that some situations work for some families and some don't. So there's a situation where a family was really appreciative of a visit in the NICU to talk about something that was in the future and not NICU related, and getting ready to they were weeks and weeks away from leaving the hospital, but they were really appreciative of having something to look forward to with their child after their NICU stay, and that being research participation. And just a couple weeks after that conversation, I approached another family, and they did not want to hear about anything after the NICU. They were not ready to speak about what could happen, what life will look like, anything. They were open to taking a brochure, and many weeks later, they reached out saying that they wanted to learn more, and expressed that that was just not the time that they were ready to talk about it. And fortunately, they were open to receiving some contact, to getting our contact information, and then they did reach out later. But I think that that can be challenging, that it's not a one size fits all ever. I think that's probably, I mean, from here on the panel, we work with very different populations, but if you create a script, it's never gonna work for everyone. And there is some wiggle room in every script, whether it be that you need to do things a certain way, but the way that you approach the situation, the way that you lead into it, can be different, and that is very hard to know before you meet the person and interact with them. And kind of being open to that, you will never find the one trick that works for everyone, and then you will recruit every single person you speak to after you discover this thing. And if you do, please let everyone us know. That would change the research world. So that can be challenging, and I think it's an ongoing challenge, and it's something that we learn from every time that it happens.
I think one of the most, whoa, hold on.
Jennie, I'm imagining you're getting some reverb or hearing echo.
I can fill in some time here as
Thank
Jennie
you.
recuperates. I mean, sometimes it's just a patient says no, and that's like that's just that. And it's like, the hope that you have going in is quickly dashed, and that's okay. I mean, it's like just really consent at every step. I've never had anyone be particularly mean or negative. I think mostly the challenge is that patients are like, is this going to delay how long I'm here for in the emergency department? And well, generally we try not, that's our goal, is to not interrupt care or delay the discharge timeline. But any kind of additional step does feel like it would be lengthening the stay, even if that's not exactly true. So um, just any no is a thank you for your time anyways. All right, Jennie, are
Yeah,
you
technical difficulties. My apologies. I think, I mostly I've not had very many hard experiences, but I was in a room with a patient and approached them, and they were agreeing. So I was going through the consent form with them, and while we were in the middle of that, they had a family member join them in the room. And I don't know if they were just arriving or if they were somewhere else and coming back, but the family member was extremely, I would say, mistrustful of the study, and also found it really inappropriate, in fact, that I was even trying to recruit the patient for a study. And then it started creating some strife between the patient and the family member. And like, I at first was like, I would love to talk to you about any, the concerns that you have. And it became clear that she was not open to being comforted. So I essentially just just ended the interaction and was like, I apologize. I meant no harm, and I will step back and thank you for your time. I really appreciate it. But I think what I learned from that is you have to read the room. Sometimes it's not it's not appropriate to try to help people understand, and it's better to back off in some situations.
Yeah, thankfully, right now, or at least across the various studies that I've been in, I haven't had very perhaps memorable experiences as mentioned before, fortunately. But I think that most recently in working within other positions, the mistrust is definitely a big thing recently when it comes to federally funded or federally tied programs, and so that was a sort of a bigger issue when it came to talking with folks, specifically talking about like return of results, and the uncertainty of the program. What will that happen, or when could I have that, and that sort of thing before before getting or enrolling into the study, so that understanding more or less the ambiance that's occurring in our social environment, one could understand where that mistrust is coming from. And so acknowledging that uncertainty perhaps is definitely necessary. I think with folks that have a very strong mindset of having a mistrust with any factor of your study, acknowledging that, thanking them for their time, and moving on to other potential participants is your best route to do. What I've learned from those types of experiences for me was understanding that those things might come through within your research studies, understanding that you do need to address those uncertainties as well. In my specific circumstance, I was noting them that we really don't know what the study could look like in these months, but we will continue to communicate. And fortunately, our program was very good in that sense of communication. But nevertheless, I mean, it's not really a strong sort of answer to then folks come in and be like, okay, great, I'm going to do it then. Some folks will say yes. Some folks will say, no, thank you, not at this time. One way that I did address one specific individual with a certain mindset was like, I completely understand. Let's set up maybe a follow-up call down the road and see if maybe that it would be an appropriate time then. And that's what I eventually did do. And so that is, for example, maybe maintaining communication with that potential participant, seeing perhaps if that mistrust may have swung one way or the other. And then perhaps, at that time, seeing if, you'd able to recruit them or not at that time. So that would be sort of the way that I would try to navigate a similar situation like that too.
I can jump in, and if you'll indulge me, I'm just going to share a story from my clinical career that I think applies here. So I was doing palliative care, social work in the hospital setting, primarily at the VA in Los Angeles. And I vividly remember I was pretty early in my career, and I went to see a veteran and his wife. And I tend to be pretty friendly, try to smile, try as a way to build rapport. And I thought everything, I went with my team, I thought everything went okay. And then I got some feedback the next day from one of my team members that the patient and the wife did not want to see me ever again because I smiled too much and made light of their situation. And so it was a really, really important learning experience for me. And I decided this was a long-term, this is a patient we were consulted on, and I wanted to apologize and try to make it right as much as I could. I'm not saying that that's the right approach if you're to go back is not necessarily the right approach if you are approaching about a study. But in my role, I did go back and I apologized, and the wife said something that really has stuck with me for my entire career. She said, "You were the easiest target for my anger." And so I think that is the sort of takeaway that I would like to leave you with for this particular question, that sometimes if you are the research coordinator or you're the recruitment person and you are going in, you're the easiest target for that anger. And as the other panelists said, it's going to happen. Somebody might be angry at you. They might kick you out. They might not want to talk to you, but they might be very polite and say, no, thank you. This is not for me. And so I think not internalizing that is really, really, really important. So it's going to happen. It doesn't mean that you did anything wrong. It doesn't mean that your approach is wrong. It doesn't mean that it has anything to do with you. You might just be the 30th person to walk into their room that day, or the person who, it's just, for some people, it might be the straw that breaks the camel's back for them, or it might just be that you're an easy target for their frustration and their anger and their angst and their overwhelm. And that doesn't have anything to do with you necessarily.
Great. Did anyone else have anything else to add to that question? Okay.
I do. I have one more, but Jaime, you're reminding me I can tap back into my past life. When I was an inpatient clinical research nurse, I worked with a lot of patients who were on study for a very long time, Alzheimer's drug or just annual visits or cancer treatments. And generally, people were very excited to be able to like be given the opportunity to participate and even, in with the difficult cancer diagnoses. But I did have one patient who just never seemed like she wanted to be there. And then became really important, and this isn't for retention or recruitment. Well, I guess it's retention. I just had to be very clear every time that, participating was optional. And you can say that in a way that's, maybe not very positive, like you don't have to be here, which is what, like, maybe that is what we're saying. What we're saying. You don't have to be here. You don't have to participate. I can tell that, you aren't, you, like, this isn't where you want to be. And I just want to make sure that this still is an option and you do have other avenues. And so just checking in that setting when somebody really is pretty negative and is still showing up. Those situations didn't come up very often for me, but they were the most memorable.
Great. Thank you for that addition. So I have another question for you all. How do you communicate with people and communities from different backgrounds than your own? And I think we'll put that in the chat. Perfect.
I can start with this, I guess. So for me, well, I guess it really depends on more or less the study objective. So within the sort of clinical and atmosphere here, well, the current atmosphere that I'm in, if they're bilingual and they're Spanish speaking, I'll just revert to Spanish. I mean, simple as that. I'll communicate them in their language, and address any questions and concerns they may have through Spanish in this case. And that's also, within international settings, that would be the same way too. However, with working with Indigenous communities specifically, especially from the Southern Cone, understanding that there might be, issues with communicating with that native language. So you would also need to do a little bit of research of what, this language translates to in, for example, in my case, Quechua, which is one of the indigenous languages in Ecuador. So, understanding what are some words that are used and putting that into your script will be helpful for you to be able to, talk and communicate with individuals. But again, kind of bringing me all the way back to what I said initially, you should by this point have already created some repertoire, some communication, some community building to understand that landscape, right, of those language barriers that you may fall into, cultural barriers, of course, that you also may fall into as well. And if you're looking to work with communities that, in my case, for instance, I'm part of a big indigenous nation that has various communities. It's not like we all know each other. So, being able to know more or less the community members there and working with community members is also a great way to be able to create relationships as well. And also knowing, the perception of, the local community of research. Like, do folks, work with other research studies, with research in general here? Is there perhaps perceptions such as like, do they feel that research is very much of a knowledge extractivist activity? Going across that sort of hurdle as well is important to understand too, if you're looking to, do an effective research study. And then, of course, within my clinical and atmosphere here, also understanding, perhaps their relationship with medicine, and maybe they have a bad relationship with medicine, acknowledging that as well, and being able to address, those potential complications, and even like we've all been saying before, respectfully noting that if they're refusing to say no, it is because they really, all these other factors are influencing them to say no, and you have to respect that. So, understanding, of course, respecting why the no is one major cultural thing, and of course, addressing the language being another. But of course, the other thing too is making sure that, in my perspective, before working with folks that are from other backgrounds, and making sure that you built those relationships beforehand is necessary and key for you to be able to then effectively work with these individuals too.
Back to the point I brought up earlier about communicating, that point about treating other people better than you want to be treated, I think goes far with this question. It's impossible for us to be experts on everything, every culture, every race, every ethnic group. It's impossible. But of course, we want to prepare ourselves as much as we can by humbling ourselves and recognizing that we don't know, that we need to come in ready to listen and receive. Just because I'm a Black girl from St. Louis, Missouri, doesn't mean that what I bring to the table is the same as the Black girl from New York or from Kansas or whatever. It's not all the same. When you meet one, you literally meet one. So trying to approach it like you have all knowing about culture, all knowing about indigenous history or Black history or whatever. No, we just have to be ready to establish those relationships, whatever the background is, and ready to humble ourselves and listen and be willing to learn and be intentional and show them that you're learning. And because you have listened, you're able to give things back. I didn't think twice about it, but I once had a participant come back because it's a longitudinal study. And I was able to ask a question about something that I learned about them 2 years ago. And they were like, wow, you were paying attention. Well, not just paying attention, I was building relationship and I meant it. I was being intentional about my relationship with that person. And we found areas that we connected on, and it stuck with me. So, and I think that's really important when talking to anyone, not just because they're a different background.
I'll add to that. I think that was really nicely stated, Monica, that we can't make assumptions about anyone, whether it's based on how they look, what their name is, what their address, whatever information you have before them, their diagnosis, whatever information you have before speaking with a potential research participant, and even once you have some sort of relationship with them and continuing to have that relationship through longitudinal study or follow-up or whatever it may be, we can't make assumptions and act on those. I think it's really important to create a space where you're listening, returning to that topic that we've covered many times today of listening to the experiences, especially with, so there are studies that there are often ways to adjust studies to fit whatever's needed, and whether that be how a person can park near the building and physically access the building, or if they need financial travel support, if they need whatever it may be, if they need the consent form with larger text, if they so like considering physical accommodations that can be made throughout a study, communication adjustments that are going to be different for whoever you speak with, but really not making any assumptions based on whatever information you have about a family, and offering all of the resources that a study or that your center has available to allow for participation are really important to all participants, because all of your participants are going to be coming from a different background in some aspect.
We got a question in the chat. Jacqueline's wondering, from your experience, what are the biggest reasons that participants disengage?
I can. Oh, sorry. I can start. I was gonna bring it back to, I think, some of the questions that were shown in the poll before, or some notes that were shown in the poll before, which is, the recruitment, the consent form, it can be long for some studies, and so definitely that's one way individuals could be disengaged and not participating, or not wanting to enroll in the study. Big words, definitely. And then, of course, that lack, in the sense, beyond those forms, your lack of wanting to generally create a relationship with that individual. So in this case, be able to hear them, understand them, answer any questions they may have, feel like you really want to know them as an individual for your study, like as a participant within your study. And that I think your genuine persona as well can be also influential to the individual wanting to enroll in the study or not. So those are some ways that folks could see that impacting their their decision to enroll or not.
We mainly have very short relationships with people in the emergency department. So the main thing that I see for people either not wanting to participate or changing their mind has to do with time. They either feel short on time, or they feel overwhelmed by their circumstances. And then we do have one study where it does require more of a time commitment, where they have to come back. And that for that study, that's one of the things that keeps them from enrolling, is the request that they need to come back at all. And sometimes it's distance, that they're just too far away to feel like they can participate in that kind of thing. But I would say time as a resource is their biggest reason for declining.
I'm just going to second that without belaboring it, but yeah, time.
I have a nod back at what was previously discussed, and of people having a purpose. I think it's really important for a research participant to understand why they're participating, especially in studies that don't give them much of whatever, if it's not a test result that they're very interested in, or if they don't get any information about their research participation, of really understanding that purpose, I think can help through both longitudinal participation and interest in the study. in general.
Okay, so we've kind of been talking about consents, and Veronika, I think you touched on phone scripts a little bit earlier. But if you're working with something like a phone script, how do you follow it while keeping the conversation natural and effective?
I have one where I call people kind of a lot. And one of the things, this might be just very small, but one of the things that I do with phone scripts is that I put a lot of inflection in my voice on purpose. Or I'll put in pauses, small ones, so that I'm not just like blah 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 blah, right? I'll be like, so if you have some time, I just need to ask you maybe 3 or 4 questions, like that could be really annoying, but it really keeps me from just like robot phone scripting everything.
I also have an answer. And my camera's doing funny things, so I apologize for that. Um, I worked on a trial where they didn't want to provide any scripting, and I felt just completely lost. And so then I made my own scripting, and then I gave it back to the team, and I said, you have to provide this for all future sites because otherwise there's like no fidelity. I now with our studies, we have pitches that we have that we pitch to providers and to patients, and it's really just so helpful to have it as a jump off point. Like, right now we have, I think, what, 7 people recruiting in our emergency departments, and those 7 people don't have to reinvent the wheel if we have a script and a jump off point. Um, I think it's good for efficiency, but also just consistency's sake to have a good jump off point. And it's not, something you can make your own, and you should make your own. You should present it in your authentic voice. Um, but I just really am a big proponent of having the tools that that if one person has them, pass them on to everybody else and make life a little bit easier. So, yeah.
I'll say to that, Audrey, my least favorite thing is reinventing the wheel. I always look for resources that other people have had, in everything, but specifically related to scripts. I think it's important that to keep in mind that scripts were created to assist the process. It's, at least in the research that I work in, very rarely do the questions need to be either asked verbatim exactly or in the exact order that they are provided in. And it needs, like, there's often follow-up questions from the families, and you can't just ignore those. You do answer those. So I think keeping it as a conversation. In our screening questions, we have a lot of long diagnosis names, and often they're the exclusion criteria. So they're often things that families haven't heard of or don't deal with. So I like to include that in the introduction of, I'm about to ask you a list of 15 questions or 20 or whatever it may be. And some of the diagnoses I'm going to ask you about may sound unfamiliar. It's totally okay if you don't know it or don't remember. If because and with especially the ones that, like, I'm like, I tell families, you would know if your child had this. Like, it isn't like a mystery, or you're like, oh, I maybe don't remember from the NICU. Like, you would know if your child has this diagnosis. So coming in with that lens, and like, let me know if you have any questions about what I'm asking. So that's for the setup portion and actually speaking with the families. And then also I like to just practice by myself. It can be intimidating, but creating a video of yourself, looking at it, critiquing that to yourself, working with a coworker, just practicing a call, of to and asking your coworker, like, throw me off, say yes to this when it's supposed to be a no, or like, how do you approach these situations? So kind of getting ready for those calls of whatever may come up. And then going back to what I mentioned earlier of knowing what you know and being comfortable in asking certain questions, and knowing when it's gonna be, hey, I need to consult the PI about this, or I need to talk to one of my other coworkers to get you an answer on that. And then following through on that, I think is really important.
I'm just checking to see, does anyone want to unmute to ask a question, or I'm scanning the chat here. We'll give a pause so people can formulate questions, or if anyone has comments or their lessons learned they'd like to chime in with. Rebecca, I see your note. Early in our study, we kept a lot of notes of places where people had questions or were confused on our phone screenings and adapted our scripts over time. Yeah, that's amazing. I'm sure there's like sort of common speed bump spots where people get hung up.
And ensuring that the, like, say, survey is appropriate for the phone format. I've worked on a couple of trials where we had to stick, well, just one trial, where we had to stick with these flow sheet rows in HealthLink, and they were provided to us. They were just kind of copied and pasted from a paper, like visual survey that had no flow for asking over the phone. And so then, advocating for that to be changed so that it was appropriate for the, medium that we're conducting it in. I wanted to circle back. I have a question for the panel. That was from the earlier slide where people could put in what they struggle with. Consents aren't one size fits all, but there are a lot of one size fits all components of the consent, as required by the IRB. And I wonder how you all go through the sections that need to be there, but actually just like don't apply to the study. For instance, we what's a good example, Jennie? Like, like we don't expect any harm to come to you. If it does, like seek emergency care. We're in the emergency department.
Right.
And
Yeah.
and we're
That's the biggest one.
like we're drawing blood from you, but you have an IV in place. But we still, need to go through that section, and it feels awkward. And I know someone commented on that in that slide. So wondering if you all have any other comments on that.
I've worked closely with the IRB on one of our big longitudinal studies. When I joined the lab, we started with a 33-page consent form that is now down to 17. It's one of my pride and joys of my job that we've been able to make that happen. And so there is template language. There's language that has to be in there, but there's also repetitive template language. And so we've been able to work with the order of our consent form being much more front loaded in the important information. And once we get deeper into it, it's the not less important, but maybe not so relevant to the participation itself. So we like review what participation in means and what data we're collecting, and then we go into how we use that data, and then we go into how we may share that and the national data archiving situation. And so and then we've also had families review our consent forms. So getting that community partner aspect into it and someone who isn't reading the consent form to participate, but reviewing it as if they were and kind of if they're interested in it, but don't have that component within it. And then also listening to feedback that we did get during the consent process. And I think we're on our maybe 10th version of the consent form. And I think if the first families who consented were to see our current consent form, they would be very happy with the changes we've made because just the consent process is a lot shorter. And I found that in my working with the IRB, they've been very open to making it more concise and removing some of the repetitive nature of because it's a template that's provided by the IRB, and that's exactly it, that it's a template that you can adjust to make it fit the study. So I've found those components to be helpful in making the consent form fit our needs. And perhaps you're in the emergency room, you don't go to the emergency room from there. Like perhaps there's a way to work with the IRB to edit that to make it express what they need to do if they have a concern, or whether it's in the moment of participating or afterwards, but making it make sense for the situation.
And the other one, thank you, Veronica, that's helpful. Um, the other one that stood out to me is the patient who's really eager and is just going to say yes, kind of no matter what. Going through the consent with them. Um, yeah, Jennie, I think you were in the room with me when I did my first consent for one of our studies, and the guy was just like, yes, 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 yes. And I'm like, well, we're still going to go through it. Um, how do you all handle those?
Um, After every section, I know it makes perhaps the conversation longer, but after every section I go through the consent form, I do ask them, were you able to understand everything that I said? Did you have any questions regarding this section? Yes or no? Go from there. It gives them an opportunity to maybe even reflect. They will say, "Oh, wait, sorry, could you read that again?" Or I had a question regarding this. Could you clarify that? It basically gives them various checkpoints and also gives you various checkpoints to ensure that that specific individual is understanding what the study is about, their own risk and benefits in the study, and basically their enrollment. Especially with some studies, if you are making a payment, for instance, or paying the participant, what does that look like for them as well? What method? Those are probably areas where they might have questions. If they just, quickly go through them, they might miss that. So it's important to assure that there's some checkpoints around there so that they are also having or given the opportunity to basically address any questions, or excuse me, ask any questions they may have, and for you to address them at that time. So that's what I would do personally. That's what I do typically when it comes to that process specifically.
I also wonder, for those who are really eager and really excited, if there's a way to, and again, I know this adds time, which can be challenging, but put the consent aside for a moment and engage with them a little bit just around, like, what makes you so excited about this research? Like, what is it that is, really engaging you? And like, have them share, because maybe they have something to share, something to say, and once they've sort of shared that, then they would be more open to what you have to bring.
In one of the prior sessions in this workshop series, Beth Gayton, who was speaking on verbal plain language communication, talked a lot about sort of friendly comprehension checks and ways to ask questions so it doesn't feel like you're quizzing people. And she had such a nice way of doing that, and doing it from a spirit of not, again, not quizzing, but just, as Jaime's saying, sort of trying to tap into what their motivation is, or sort of get at their understanding that way. We did have a question in the Zoom chat, someone wondering, I think wondering if they can access the scripts that some of the panelists mentioned, which I assume are all sort of study specific, protocol specific scripts. If anyone has a good script that they're willing to share, that's something Allie and I would love to share out with attendees, or to share out in the recruitment materials repository box folder. And I'll put that link for the request form in the Zoom chat as well. But if anyone has a good script, sounds like people are curious to see what that looks like. And I am going to pause. Are there any attendee questions? And Audrey, thank you for asking a question. I loved that. Well, we'll give a break here and see if anyone else wants to chime in with a question before I do my next one. Okay, so the next question I wanted to go to, and I think we have time for just maybe two more questions here. This is a really lovely discussion. I was curious sort of what you do non-verbally. We've talked a lot about the verbal techniques, what's happening non-verbally, what works well for you.
I could start. One of the things that I do when I walk in is I, after introducing myself, I usually try to sit down next to the bed so that I'm not just like standing and staring at them like all the doctors are always doing. Um, so I really try to sit next to them and uh, and like look at them a lot while I'm talking to them and while I'm answering questions and when they are talking. I avoid as much as possible looking away or looking at what's on my clipboard. And even while I'm going through the consent form, I try to look at them more than I'm looking at the forms that we're talking about. It's just a couple, but
We also have
So,
the, oh, I'll be quick. We also are, in the emergency department where there's a lot of beeping and loud noises generally all around. And so just making the environment itself as quiet as possible, adjusting the lights, yeah, asking if the patient needs anything before we really settle in for the consent.
yeah, so at least within the actual process of consent, talking is pretty much the main thing you can do with via phone or Zoom. But if you're seeing folks in person, for me, when I was working at All of Us, for instance, we'd get participants to come in, and what I would do is try to engage with them sitting in front of them, like looking straight at them, because you could easily have your computer, for instance, and placing it to the side and then have the individual looking at you, but your side is to them specifically. You're addressing questions like that. It doesn't really give them sort of a viewpoint from my perspective that you're actually open to them and open to hearing what they're looking at to say or have any questions. So by opening yourself up to them, you are opening yourself up to, getting what they're looking to get. So if there's any questions that they had coming prior to the actual, research study, session, that is the moment to them, and that you non-verbally communicate to them that you're open to addressing any questions you have, and also makes you more of an open and engaging person, at least from their perspective. So that way, they feel comfortable, they feel that they're with an individual that's friendly, that's open to help them if they have anything to ask, and also of course to address any questions or issues during the process. That is a very clear way of going about that. Through Zoom, obviously it's harder because you're not with them, right? But since you are virtually with them, what I tend to do when it comes to conducting focus group sessions is looking, of course, straight at the camera and then nodding and then noting. And for me, for me, it's very important to hear, understand what they're saying. So of course, that's the main thing I do. But I'm also acknowledging when they're noting any difficult experiences, especially with patients that are talking about their issues with cognitive health issues specifically, and what their troubles are individually, or what they're experiencing within their family, are very heavy topics at times to talk about or to share from a patient's perspective. So for you as a researcher, it's very important for you to be engaged, to understand, to hear, and in a sense, non-verbally acknowledge that what they're going through. So like, nodding appropriately, acknowledging yes or no, or that sort of thing, being in a sense, emotionally acknowledging that, but of course, non-verbally are good ways for you to show that you are there to hear that. So that's sort of some of the techniques that I would do specifically in person or through Zoom.
Okay, we have one final question for you all. Appreciate you so much. I know we've sent you a bunch of different questions, some around that we didn't get to around self-care, how you handle the no lots of no's one day, um, along with lots of other items. But is there anything else you all would like to share? Just kind of a final takeaway, lesson learned, anything? I know we kind of asked this in the beginning, but any final items for the audience?
I'll add something that through the questions that you guys had sent, something that I kept returning to is we have a lot of materials presented in different ways. And I think this goes to the repository that you're building, of having a brochure, having a website, having some videos available, having being able to talk through it over the phone, having the opportunity to connect through a Zoom call. So really being open to whatever method may be the best way for someone to learn information, and having information about the study. This is, of course, for studies that have the time to have that discussion. And then along with that, in preparing all those materials, what I found myself kind of building for the study is more and more lay language summaries, and finding different ways to phrase different pieces of the study and to explain that, and having those available. First it was on a piece of paper, and then now I have a lot of it memorized because I continue to use them. And that goes along with having a really good understanding of the study that you're working with and the diagnoses that your research study may work with. But having that array of resources available, whether that be like in a binder while you're doing a call, to be able to flip to it, or to be able to refer a family or a potential research participant to it, can be very helpful, or I found to be a good resource.
Yeah, kind of what Veronika was mentioning there a little bit. So for me, what I developed the most are the actual interview guides. And so when specifically I found this very helpful when it comes to talking with older individuals, or with perhaps individuals that very easy to stray away from the main question that one's asking. I have a lot of prompts that I add within my scripts of saying, okay, like, not okay, but like but basically acknowledging that they, whatever at the point they're addressing at that time, acknowledging that, and then yes, understandably, this is what you experience, but let us bring our our talk back to this topic that we're talking about. So there some transitions for you from going from perhaps something that is off topic to back into topic is important for you to have within your script. At least that's what I found, because then at that time, it could be really quick. It could happen. You're sort of in the middle of the study, and then suddenly like that sort of event happens, for you to sort of have that plan and bring it back into the conversation, because you're also in a sense to playing against time as well. And if you have a script and you are trying to touch certain sort of topics in the area, that's sort of one of the things that would help you to get back into that sort of time regimen. But also within your script as well, note areas where, if you're going to be working with patients or individuals that are very keen to doing this type of behavior, to note which areas of the study or the script you're going to be needing to cut off and go into the next session. If your session, for instance, or your study is across various sessions or various focus group sessions. That's what I'm currently doing, which is 5 focus group sessions. And so for me, if there's something that I wasn't able to talk to because either one, I've had patients that perhaps have strayed out of the topic, or two, maybe there's an area that we needed to dig even deeper because it was, very rich and also, related to what we're looking to essentially understand further. Just have a plan within your script to like, okay, if I don't get to this point by 12 or 1 o'clock, then I'm going to move this to session 2 instead. And we will leave this off and then transition myself out of the session this way. So having those little game plans within your script will also help you to make sessions very smoothly. And what also, I know there was a question or comment about transitions from one topic to the next. Those will be the areas for you to also note where you transition from one topic to the other. So building the script will also allow you to see where the transitions will flow in seamlessly too.
Well, I see we're right at 1:30 here. I don't want to cut anyone off, but really appreciate all the panelists sharing with us today. And we're going to send out a summary of what we discussed along with a recording. And yeah, appreciate you all and hope everyone has a good holiday season. Thanks, guys.
Thank you all.
Thanks for organizing.